abdominal exam today that will consist of me listening to your abdomen. I'll also be tapping on your belly a little bit, and then I'll finally gently be kind of palpating on your abdomen. Let me know if anything bothers you or hurts you. So the next thing that we want to do, first of all, is we want to know how this bed works. So you'll look really bad if you go into the exam room and you're fumbling with the bed and your patient's kind of looking at you like, do you know what you're doing? So before you do anything, before the patient's there, practice with the bed. So just you want to make sure, do I know how to get that down? Do I know how to get that up? Can I work the bed? Okay, it seems really silly, but if you don't know how to work the bed, you're going to have trouble. They're all a little different. Same thing with this one. So this one basically, it just lever here. As soon as that patient lies down, you should be going for this foot support. Okay, please don't leave your patients hanging there. Let's just do it for a second. Okay, so here we are. Would you please? First of all, let's cover our patient up. So we always want to make sure we have a gown and a sheet. And I encourage you to practice with the gown and the sheet because it's a little awkward if you don't know how to use it. If y'all are just sitting there in shorts, this is kind of like a half sheet. This is like a cheap sheet. You don't even get a full. What kind of bed is this? Yeah, this is like a pediatric. Is that it? Wow. Emory's getting really cheap. Where's all that tuition money at? Oh, wait. There you go. Now we're talking. Okay, so let's say I said, please lie down, sir. Am I going to do that to him? No. Okay, I'll let you sit up. That is not comfortable. So as soon as you ask your patient to lie down, you better be going for that. And we're looking and we're watching the Auscultation, and we're just like, oh no, the poor SP's like stomach crunching. So please don't do that. Okay, so sir, would you please lie back for me? And then immediately, and this is a noisy bed, so you might want to warn them, gosh, you can hear this loud sound because I don't want to scare anybody. Let's see, I'm trying to figure out which, I'm going to just stay right there, and I'm just going to maneuver you. So everybody can pretty comfortable. What was that? Okay. So let's see. So the next thing that we're going to do, okay, so we've got positioned our patient. He's fine with his hands like that. Actually, if you don't mind, sir, if you would place your arms at your sides, because that's going to, we don't really want him to cover up his xiphoid there, because we're going to get to that in a second. Okay, so that's our patient positioning. So as far as, I'm going to go ahead and pull this gown up. You can help me. And so you're going to make sure you can see the costal margin. And then I like to kind of tuck the sheet just like that. Okay, that's perfect. I can see all four quadrants. So I'm just going to kind of look. I'm looking, sir. I'm looking for any signs of previous surgeries. I'm looking for distension, anything like that. I'm noticing his umbilicus. It's not protruding outward or anything like that. Okay, make sure you say what you're inspecting for and actually inspect. The next thing is auscultate. We're going to auscultate for bowel sounds, for bruits, for hums over the splenic area, and then also over the liver. So, do y'all notice on your stethoscopes how they aim this way? Okay, so you'll figure out, what? So, there you go. Okay, so I'm just going to be listening, and it's helpful if you just kind of touch either patient's shoulder or the bed. Okay, so for bruits and renals, you're doing great, sir. Iliacs, and then we would do femoral. Okay, so that's about how long you would do. You know, hold it there for a little while. I heard a little bit of that was enough for me. Okay, so kind of quiet. It wasn't particularly noisy. Questions about that? Pretty good with that. Pretty easy, straightforward. Percussion. So this is where it gets fun. Okay, so if you're, percuss with your dominant hand. So basically, I'm just going to percuss. I'm just going to kind of percuss around. So. Hear that gastric bubble? That's tympany. Can you all hear that? Doing okay? That's dullness. Y'all hear that? Ah. That hollow sound, that's tympany. I would expect that here. So basically it was kind of varied. Nothing too, that stood out. If I was worried, like if all of a sudden right around the periumbilical was tympany, 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 and this is all dull, I might do that shifting test, something like that. So just make sure you percuss and kind of percuss. When I percuss, I like to percuss on this finger, and I percuss with 2 fingers. I know Bates talks about 1. I keep my other fingers out of the way, so I don't want my whole hand on the patient. And I lift up on the second one. First one is just and I hit pretty hard, and I hit on the right through the bony part. So just kind of, I do it twice. Boy, there's nothing behind this wall, is there? All right. Oh, wait. Ooh. All right, you get the idea. So practice your percussion. Okay, so we did over the gastric bubble, the suprapubic area. So we're going to percuss over the liver. So this is where we want to see where our clavicle is. So we see our clavicle mid-clavicular line. So I'm going to start up high. Hear how thuddy that is? That's lung. Do you hear that versus that? Do you all hear that? Okay, I put my little sticker there, and I'll put the sticker there. I'm going to get my handy dandy centimeter ruler, and I get about maybe 11 or so. So 6 to 12 in the mid-clavicular, 4 to 8 if you're over in the mid-sternal area, right over here. Okay, so that's our percussing our liver. Now, percussing over that spleen business, that's kind of a little bit tricky. Sometimes you can go over the patient, but I find that that doesn't work very well. So here's our costal margin, okay, and here is our anterior axillary line, mid-axillary line. I'm going to follow this around. Here's my last inner space. So take a deep breath, sir, and blow it out. So I didn't really hear a change. If it would have been tympanetic and then during the inspiration it became dull, that might be a sign of an early enlarged spleen. I kind of heard dull and then it stayed dull. Does that mean he's got a huge spleen? Probably not. Just a finding. So that's not my favorite test, but that's how you work it and figure it out. Okay, we're going to palpate the 4 quadrants. So this is where we're going to have our patient bend their knees. So if you go ahead and just relax point your knees up to the ceiling. Now we could have done this the whole time, but it's going to block you guys. Let's see, I'm going to do this a little bit more. Take you on a little trip. All right, so always protect your patient here. Okay, so palpation. I'm going to start, if you can't see, kind of maneuver around. Just going to do one hand and just cover the area. If they have a lot of area to cover the whole area. I'm just being pretty gentle, one hand, just kind of like you're doing a massage almost, just kind of getting a general sense. Next, I'm going to go a little bit deeper, hand over hand. And during this time, you can say, breathe in and out through your mouth. Just let me know if anything's bothering you. And I'm watching the patient's face and eyes, if they start to wince or anything like that. Okay, and it all feels completely normal. And he's pretty relaxed. You're not guarding at all, which is fantastic. Yay. Okay. At this point, I'm going to go ahead and palpate the liver. A couple of different things. So the Murphy sign, I could go up against this costal margin and place my hand, take a big breath, and all of a sudden, if he's breathing and he goes, let's say you all know the feeling where you get startled or somebody scares you or something's about to drop or whatever, and all of a sudden you go like that. That's the Murphy sign. Okay, so if I put my hands here and he takes a big deep breath, and as he's taking the deep breath, he stops, an inspiratory halt. All of a sudden, he stops breathing. It's because I touched his gallbladder, which is inflamed. That's a positive Murphy sign. The second way you could do that is if the way that I prefer, and I don't deviate from Bates very much, but this is such a good test in the ED, or if you're trying to make the decision between you're going home or you're going to the OR and you only get one try, I come over along the costal margin, take a big deep breath, blow it out. And as he's blowing out, I go, 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 and I press right there, and there's a little bit of liver edge, but if he all of a sudden went like that, that would be my positive Murphy's, and we'd be going to the OR. The other hook technique, the way that Bates described it, is I hook, and then you take a big breath, and then as you're breathing, the liver comes down, you know, that would be problematic. My preference is you take a big breath, blow it out, and as he does, I go along for the ride, and at the very end, I do a sweep up and under the liver, and I can actually feel his liver border just a little bit right there. So that's kind of how I do it. Inspire, expire, sweep. Bates, stay still, they breathe. I just find that if people are uncomfortable, they typically won't take a deep breath. So that is palpating the liver, the spleen. Okay, spleen's a little tricky. So with this, you're going to lean this direction. So you're just going to turn your body and lean this way. You put a hand behind the patient and a hand under the costal margin. Same thing. I'm just going to place my hand and then have you take a big deep breath. Okay, then blow it out. And I'm not really doing anything. And then I'm going to go up a little further, take a deep breath, blow it out. And you're trying to kind of just support the back and with gravity try to get it to roll over. Let's do maybe one more. Deep breath, blow it out. Okay, so my preference is we're going to do a little different. Take a big breath, blow it out, and as he blows, I go in and try to fill like that. Okay, so go along for the ride, and get an extra little, try to feel it. Okay, so let's have you roll back over. Is everybody kind of clear on that? Two different ways. So the Murphys, the way that Bates kind of talks about it, you start low, you take a deep breath. You go up a little higher, you take a deep breath. You go up a little higher, you take a deep breath. And all of a sudden, if I get up here and you take a deep breath and it's inspiratory halt, that would be a positive sign. That's the way they kind of describe that. CVA tenderness. Let's have you go ahead and sit up. And why don't you kind of turn this direction with your legs. So this is where this person maybe we think they might have pyelonephritis or something like that. We're going to find the costal vertebral angle. So here's his last rib right here. I'm just going to put my hand on your back, sir, and I'm going to tap gently. Okay, again, any problems with that? Doing okay? Now, if somebody really had peritonitis, all you'd have to do is do that. Meanwhile, he's going to look really, really sick. Wow, my pants going to fall off. Let's see. Okay, so was there anything that I missed? Everybody pretty good with that? Now we've got some special tests.
Question.
Yes.
You said you would call a positive Murphy's sign your sweep of the liver.
When they do the inspiratory halt.
Okay.
The inspiratory halt is when your hand touches that gallbladder and they stop breathing because it hurts. So whether you stay still and they breathe, or whether you go along for the ride, and then it happens, you're doing the same test.
Okay.
You're just trying to see, it's inflamed. So I think you were next.
Will it be obvious when they stop breathing? Like, how do you know that they're not fully
They go.
inspired? Okay, so they'll
It's pretty obvious.
actually wince or something.
Yes.
Okay.
And you'll have more signs. This is not a normal person who just walks in the street. This is somebody who's sick. They're nauseated. They've been having pain. They've been having a lot of gas. So it'll be other stuff going on. I think there was somebody else over here.
I may have missed this, but palpating the aorta.
Yeah, we didn't do that. So let's go ahead and lie you on back. And let's keep your knees bent. So basically, we know where the aorta lives. So basically what I'm going to do, take a big deep breath and blow out. This just relaxes the abdomen. And I'm going to go, go, go. Okay. And, oh yeah. Right there. Okay. Can you see my hands move? They're actually, are you doing okay? So I'm pressing on either side of his aorta and my hands are bulging. Like every time? Okay, I'll try not to.
No,
So I was about this far. So basically I have him take a big breath. I go along and then I clamp down and then I try to walk out to where that's happening, okay? And then you just measure it. So yes, thank you. Was there anything else I missed on that first section? Shifting dullness. So this is the person where we're not quite done yet. All right, so let's see. Shifting dullness is where during my percussion, I noticed tympany, 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 and I marked it out. And with air filled in the bowel, it's all going to kind of be here, and you have fluid here and here. So if I marked it out with my sticker, and And let's have you go that way so everybody can see. So I had a round circle of tympani, actually, and go all the way like that. Okay, now fluid's going to go down, right? And air is going to move up. Now all of a sudden I'm doing this and I'm like tympani, tympani, tympani. It used to be over here was my round circle of tympani. Now when I go over there, it's dull. Does that make sense? So with gravity, this air, you know, basically air rises and fluid goes the other way. So my little circle changed. So basically the fluid's down here and the air is now up here. And that just indicates ascites, or fluid in the abdomen. A fluid wave. Okay, now we're going to have you come back on your back again. So this is a lot of, you're getting your exercise today. So this is a very strange test. So this is where you're going to take your right hand, and you're going to put it in your abdomen, kind of, and it's kind of hard to make your hand do it, but kind of like that. And then the idea is I'm going to have this hand on this side and this hand on this side, and I'm going to do that. And I'm trying to determine, like, and some of this is just, you know, jiggling. You can just see normal body tissue. But let's say he had fluid in there. He's trying to keep the superficial layer from kind of going over, right? So if I push on this side and he actually has fluid and I feel it slosh over and hit my hand, that would be, again, ascites. Usually you're going to know when a patient has ascites, there's big, you know, fluid-filled abdomen. That's just one test. So you're basically, yeah, you can do that too. Whatever's more comfortable with your hand, because that is kind of weird when you do that. And then I'm just going to say, okay, I'm just going to tap you here, and then I could do that way. You know, usually I tap with the dominant hand and feel with the other hand. And I'm just trying to see if fluid goes sloshing over. And he's just trying to keep the superficial layer from moving. Rebound tenderness. So this is somebody we already know is sick or uncomfortable, so we don't just do this on somebody who walks in. And probably it's going to be in the right lower quadrant. So I know this hurts, sir. Does it hurt worse when I press down or when I let go? When I let go, if he hurts worse, that's peritonitis or peritoneal signs. He hurts because I'm pressing right over the appendix. But it hurts more and further when I let go. That's a worrisome sign. So that's rebound tenderness. And then how do I attempt to distinguish between a mass in the abdominal wall and one that's in the abdominal cavity? So let's say you have this big mass, and I can't figure out if it's over, you know, here's the muscle layer. Is it above the superficial to the muscle layer or deep to the muscle layer? So I'm palpating this mass that I feel, and I'm going to have you raise your head and your shoulders off the table. So that tightens up the abdominal wall, so I'll let you relax. So if it was deep and he tightened up, I wouldn't feel that, right? Because the muscle's tightened and I don't feel it anymore. But when he raised up, if I still felt the mass, it's superficial. It's in the muscle layer. Does that make sense? So you just have them raise their head up and you're trying to determine, is the mass underneath the muscles or up above the muscles? It's an okay test. Sometimes it's good to do that. We already talked about Murphy sign, Courvoisier sign. So Courvoisier sign, he's jaundice. I feel a palpable gallbladder. It doesn't hurt. Psoas sign, this one gets a little tricky. So let's have you rotate that way. We're always going to do it on the right because the appendix is on the right. So what we're going to do is I'm going to passively extend his thigh. Okay, so extension of the thigh is this way. So I'm just going to hold your leg. All right, and I'm just going to move your leg around, okay? So what I'm doing is I'm taking his thigh and I'm passively extending it, okay? Or I could do this, sorry to keep making you move all over the place, and on your back, I could say, okay, in the book they have the leg straight out, but I think that's hard for patients. I want you to take your leg and do that, okay? Ready, go. Okay, so that did the same thing. I had him flex against me, or when patients are sick, they don't want to do these party tricks, okay? This is like, you know, do this, do that, try this, do that. I like to, you know, minimal, you want to get away with doing minimal manipulation. So rotate them over, just, does this make it worse? That's going to be helpful. So that would be a positive Psoas sign. The Obturator sign, this is where you do internal rotation of the thigh. So again, I'm going to control the leg, and internal rotation of the thigh means, and we'll talk more about this in musculoskeletal, but I'm going to take his foot outward, and I'm going to keep his knee in line. And what I'm doing, if you think about it, external rotation is when you cross your legs like that. Okay, everybody's pretty good with that. Internal rotation is the opposite way. Okay, so it's the femur that's rotating. So when my femur is turning that way, that's external rotation. Don't look at my foot, but it's my femur went that way. That's external. and my femur goes that way, that's internal. So I wanna do internal, and so basically I'm just gonna do that. Or I could externally have him try to, against me, so push against me. Okay, so he's externally rotating. Again, it's better, sometimes what I just do is I wiggle him back and forth. Does this make it better or worse? Change anything? Just kind of back and forth. You're just trying to wiggle that muscle to see if the appendix moves, if it makes it more uncomfortable. I think that's everything. Is there anything we need to do again, or anything people aren't clear about? Let you sit up if you want to. Thank you.